Welcome, everybody. Delightful to welcome you to the Richard A. Pallet Endowed Grand Rounds in Cardiology. This was first established in 1980 by Theodore Spack, and now its purpose is to sponsor an outside expert to provide unique expertise and professional development for fellows, residents, medical students, and faculty. And we're delighted that today's guest for this is Dr. Nissen, who will be introduced momentarily, and who we had a pleasure to hear also erudite discussion this morning. So now we will welcome Dr. Nissen.
Sure. Hi. It gives me great pleasure to introduce Dr. Nissen to present at our Grand Rounds today. Dr. Nissen is the Chief Academic Officer for the Heart and Vascular Institute at the Cleveland Clinic, the Chair in Cardiovascular Medicine, and the Professor of Medicine at the Cleveland Clinic College of Medicine at Case Western Reserve University. From 2006 to 2019, he served as the Chair of the Department of Cardiovascular Medicine at the Cleveland Clinic. In 2006 to 2007, he served as the President of the American College of Cardiology. Dr. Nissen has an incredible body of work, and his career research has focused on the application of intravascular ultrasound imaging to assess the progression of coronary atherosclerosis, conducting over a dozen randomized clinical trials. Most have been published in the New England Journal of Medicine and in JAMA. His contribution to scientific literature include approximately 600 journal articles and 60 book chapters. Dr. Nissen has also extensively written on the subject of drug safety. In 2001, he co-authored the first manuscript that raised concerns about the cardiovascular safety of Vioxx, which was then withdrawn from the market 3 years later. In 2007, he authored a New England Journal of Medicine manuscript, that demonstrated that the widely used diabetes drug Avandia raised the risk of myocardial infarction, eventually leading to the 2010 withdrawal of the drug in Europe and severe restrictions in the United States. As a result of his many accomplishments and extremely hard work, Dr. Nissen was selected by Time magazine in 2007 as one of the world's most influential people. In 2015, he was named by Thomson Reuters as one of the world's most highly cited physician scientists. So without further ado, I will turn it over to Dr. Nissen.
Okay, well, thank you very much. I'm okay to start now? Okay. Well, look, it's a pleasure to be with you, and thank you for the honor of giving this named lecture. And I hope I can provide you with some valuable thoughts. We are living, as you know, in an obesity epidemic, and it has profound cardiovascular implications. That's what I'm going to talk about. My disclosures are shown here. Please note that while I do work closely with the pharmaceutical industry, I don't take any honorarious speaking or consulting fees for any of this work so that I can remain independent. Now, I think you all know that this epidemic is out of control globally, but America leads the way. You will see a projection that probably is going to come true, that a BMI of over 30 by the year 2030 will be present in approximately 30% of Americans. Other countries a bit behind, but they're coming up very, very quickly. So I worked with the Wall Street Journal a few years ago to do this article. It was a huge article, and we spent a long time working on it because we wanted to make a point. And what you see here is that cardiovascular disease peaked in the 1950s, very, very high rates. And then all of the modern advancements has led to this extraordinary drop in the risk of heart disease. And you see then at the bottom of these curves at the right, they begin to level off. And if you look at the inset at the right, you can see that heart disease kind of nadired at around 2011, 2012, and it is now going back up. And the purpose of this article was to warn everyone that all the progress we've made can be reversed if we do not tackle the obesity epidemic. So the question is, how important is obesity as a risk factor for coronary disease? A number of years ago, this was very controversial. One of the best studies is the Interheart study done by Salim Yusuf that looked at acute MI in 52 countries on every continent, and it was a case control study. And this is a really pivotal set of observations. Everybody understands smoking greatly increases risk. Diabetes increases risk for both men and women. Hypertension. Abdominal obesity is right up there. And it is important to understand that it is in the same league with these other very important and commonly addressed risk factors. Now, let me show you something else from Interheart. Odds ratio for myocardial infarction for smoking, diabetes, and hypertension, and then obesity. But if you smoke, have diabetes, and have high blood pressure, your odds ratio is 13-fold increase. And if you add obesity to the mix, you're now at 21-fold. Now, I would point out something about this. These are interrelated. If you're obese, you're more likely to have hypertension or diabetes. So, in fact, these drivers, the abdominal obesity problem is driving a huge amount of morbidity and mortality. Now, it has been debated about the effect of obesity on all-cause mortality. And let me show you some legacy data. This is New England Journal about 20 years ago. And what it showed was that there was a nadir of mortality with BMIs in the 22 to 25 range, 22 being really optimal, but 25 being fine, and then a gradual increase from there. But there was also this suggestion that at lower BMIs, maybe people didn't do as well. Now, I know you've all probably thought about this. People who have low BMIs are sometimes chronically ill, more likely to be smokers. It's hard to get a really clean look at this. So this has been a really challenging time because there has been a lot of discussion of the so-called obesity paradox, meaning that obesity may not be as bad as some of us think it is. And so there have been a number of studies, and I want to show you one of them that was very influential. And this is from CNN's website, and it said, obesity and low BMI linked to increased risk of death. And so there was this study, and here it is. It's a large UK study, 3.6 million patient years, and it showed that there was a low risk of mortality at a BMI of around 25, and then it went up pretty steeply as you went down to lower BMIs. But even worse, these authors, published in JAMA not very many years ago, showed that in the subgroup between 30 and 35, they actually looked a little bit better than the people that had low or moderate BMIs. And so confusion set in. And the authors wrote in this paper that grade 1 obesity overall was not associated with higher mortality, and overweight was associated with significantly lower all-cause mortality. This caused, amongst many of us, a large amount of consternation. And it turns out it's wrong. So if you go forward now to 2018, you see a really well-done study in JAMA Cardiology. This is a pooling of 10 studies, 3.2 million patient years. And what you can see here, this is lifetime risk of cardiovascular morbidity and mortality in men. Please note that the underweight category over time has the lowest risk. The greatest risk is with people who are severely obese, and there is a graded dose response such that more obesity equals more cardiovascular morbidity and mortality. But you have to look out a ways. You don't necessarily see it. If you do a study that's only 10 years in duration, you may not see a statistically significant effect. So the way to think about obesity and to talk to patients about it is, it's not that it's going to make you sick when you're 30 or 40, but watch out when you get older. You're going to have a shortened life expectancy if you're obese. Here's the same data with women. You know, it's a little bit messier, but the bottom line is graded dose response, more obesity equals more morbidity and mortality. And part of the problem with this whole obesity paradox, which is still getting a lot of discussion, is it's confounded by smoking, which is associated with lower body weight, but high risk. The time horizon needs to be long enough to observe the full effects of obesity. And some individuals with low BMI are very thin because they have other chronic or incipient diseases that result in relative cachexia. And so you got to look out further. And then you suddenly find, oh, this person's thin because they got pancreatic cancer that wasn't detected. So it's very complicated. And my view is, you know, you really can't be too thin. Now, let's look at the effect. What's the magnitude of the effect? If you see patients, and I certainly see them in the coronary care unit and in the clinic, who have BMIs of over 40, their reduction for men in life expectancy is 9 years. And even in the 35 to 40, it's about 6 years, and 30 to 35, it's about 3.5 years. Somewhat less effect in women, but it is still quite clearly there. And so I think you can say to patients, look, your life expectancy is going to be compromised if you are in these obese categories. Now, what about obesity and other cardiovascular diseases? Well, heart failure, unbelievably dramatic effect. You know, it is, and a lot of this is heart failure with preserved ejection fraction, but it's still very disabling that as you become more obese, your risk of heart failure goes up almost exponentially. Coronary disease and stroke, more of a linear relationship, but a strong relationship. And this is adjusted for age, gender, race, smoking status, alcohol use, etc. Very, well-controlled study. This shows you the incidence of CHF. And again, note the time horizon, that if you want to understand what obesity does, you've got to look out further, as they did here in Framingham, and look at the shape of the curve in obese patients for incidence of heart failure if you go out about 15 to 17 years. It is really frightening how much the risk of heart failure goes up in obese patients. And even in overweight patients, it goes up pretty steeply. This is women, same story. The obese and overweight patients have a dramatically increased risk of heart failure. And again, a lot of this is heart failure with preserved ejection fraction. An interesting topic for perhaps another day. Atrial fibrillation is a disease that we're all dealing with more commonly. As people age, atrial fibrillation becomes a much higher probability event, but it is driven at least part by obesity. We think we understand the mechanism. I may be able to get to that, but atrial fibrillation and obesity go together, and again, in men and women. What about childhood obesity? Every once in a while, and please don't tell anybody I said this, I will walk into a McDonald's or a Burger King. I'm mostly there to observe. And you see children that are, 15 years old and very obese. And so this shows you what the effect is if you have only childhood obesity, your long-term risk is actually not very great. But if you have childhood and adult obesity or adult-only obesity, your risks are very high. What does this tell us? It tells us we need to get into the schools and identify young people that are obese, because if we can intervene, then their long-term risks, as shown here in orange, we can prevent them from developing these morbidities associated with obesity. It's a really important message. What about fitness? So Swedish military conscripts, age 16 to 19. On the left is cardiorespiratory fitness. The top decile for fitness had a very low long-term rate of cardiovascular disease. The least fit, look at the difference. It's just enormous. So fitness counts and body mass index counts. Again, this is a very large group. It's over 1 million Swedish military conscripts, age 16 to 19. If these people at that age had class 3 or class 2 obesity, their incidence of major cardiovascular disease and death went up in a very exponential fashion. And only the normal and underweight patients did well. So the question then is, does fitness, what happens if you're fit but fat? What happens if people will sometimes say to me that I see in the clinic, well, look, I know I'm obese, but I'm really fit. You know, I can go a long way on the treadmill, or I can cycle, or I can do all these things. And so let's see what the data actually show. And what you see is that fit men who are obese, shown here in blue, do better than unfit men who are obese. Not as well as non-obese and fit men. Unfit men who are not obese do pretty badly. If you go to women, you see the same thing. It's actually exactly the same relative risk. So fit women still have a 39% increased risk of mortality from cardiovascular disease. But if you're unfit women and they're obese, they have almost double the risk of mortality from cardiovascular disease. And so the lesson is fitness helps, but it doesn't eliminate the risk. Here's yet another study. And again, it shows that if you're obese and you're physically fit, your risk is increased about 60%. If you're obese and you're not fit, your risk of CV death is increased 5-fold. Same thing in overweight and same thing in normal weight. So what you really want is you want to be fit and thin. And that puts you in the category of the lowest risk. Now, what about metabolically healthy obese patients? I know you see them, I do, where they come in and, you know, they're pretty obese, but their blood pressure is okay, their triglycerides are okay, they've got a good HDL, they don't have hyperglycemia, they may have an increased waist circumference. So if you have 3 or more of those, then you're considered metabolically unhealthy, but you may not have any of them. And so the median follow-up was 12 years and 7,600 cases. And here's what you see. And just like the fitness category, if you're metabolically unhealthy, you've got this kind of metabolic syndrome phenotype, you do badly. If you are, however, overweight or obese, and you don't have those comorbidities, you don't have a low HDL, you don't have high triglycerides, then you do better, but you don't do as well as the metabolically healthy normal weight. And so again, people should not be deluded by the fact that you can have obesity without a lot of other comorbidities, but you still have increased risk. So how does obesity cause cardiovascular disease? That's actually not an easy question to answer. Many of us think that the common soil here is insulin resistance. That with insulin resistance, you see hypertension, obesity, hyperinsulinemia, diabetes, hypertriglyceridemia, small dense LDL, low HDL, and hypercoagulability. And all of those factors are associated strongly with insulin resistance and are also associated with atherosclerosis. So here's what is this kind of constellation that I want to talk a little bit more about. Visceral obesity, different from obesity. It's obesity that's intra-abdominal. Dyslipidemia, high triglyceride, low HDL, and small dense LDL, hypertension, and elevated C-reactive protein, plus all these other things that happen like impaired fibrinolysis and other abnormalities like non-alcoholic fatty liver disease. Elliot Jocelyn, wise man, in 1927 wrote this long before the current epidemic. He said, with an excess of fat, diabetes begins, and from an excess of fat, diabetics die. Quite prophetic. And I know you all know this, but I really want you to see the numbers. This is the incidence of diabetes by BMI. If you're less than 22 for a BMI, you just don't get diabetes, don't get type 2 diabetes. If you're in the 22 to 23, it goes up a little bit. Even in the normal weight category, there's a little bit of increase, but look what happens when you get out here to a BMI of over 35. Your relative risk has gone up by an extraordinary amount. It's really, really a devastating consequence of obesity. The abdominal obesity is the core of all of this. So you have this Venn diagram. Some people are obese, but their obesity is all in their thighs and hips, not in their abdomen. And they're over here on the left. But if you have abdominal obesity, you're more likely to have an inflammatory state, elevated high sensitivity CRP, and you have elevated cardiovascular risk. You can be over here, and you see these people, and they don't have abdominal obesity, and they do better, but some of them are going to have inflammation, and some of them are going to have CVD. And this seems to be related to ectopic fat. That when you get fat in the abdomen, you get release of what are known as adipokines. They're really cytokines. They're inflammatory cytokines. And you get a lipid overflow with liver fat leading to NASH, epicardial fat, muscle fat. If you are obese and do not have intra-abdominal obesity, you don't get this ectopic fat distribution. You have a more normal metabolic profile. So it's really the visceral obesity that's the big driver. Now, here is an important insight. Let's look at somebody here who has a BMI of 30. They can have a waist circumference of around 90. Or they can have a waist circumference of around 110 or even 115. And so BMI alone is not the only descriptor of obesity. You really want to have a tape measure in your clinic and get in the habit of measuring waist to hip ratio, because it's a powerful prognosticator about who's most likely to get into trouble. And this shows you how some data about this. So if you have a waist circumference that it's elevated, and your BMI is low, you're still at greatly increased risk. If you're in the highest tertile, well, you have risk almost regardless of your waist circumference. But what you got to watch out for, and I'm going to talk about some ethnic distribution here, are people who don't have a high BMI. You calculate their BMI, you look at them and you say, well, their BMI is 25, they're probably okay. But if they have a high waist circumference, they're not okay. And it is ethnically distributed. South Asians at a BMI of 22.6 have the same dysglycemic effect as white Europeans have at a BMI of 30. Please let that sink in, because I see South Asian patients, I see a lot of them, and they come in and their BMI is not very high, but they got this kind of tummy bulge, little tummy bulge. They have a high waist circumference, and they have, at a BMI of 22, they have a lot of risk. So it really does depend on where you're from. Now, as you, I'm sure, know, BMI is also a predictor of hypertension. These risk factors are interrelated. And what you see here, even within the normal range, as BMI goes up, here are women at a BMI of a little 20.5, and that's the relative risk of 1. At a BMI of 21.5, their risk is up 30%. By the time they get to 23.5, it's up 80%. And so there's an incredible linear relationship. This is a nurse's health study, between the BMI and the risk of hypertension, and it's true for men and women both. Hypertriglyceridemia, again, doesn't take a lot of obesity. Even in the range of 25 to 29, your odds ratio, look at the odds ratio here, it's about 3-fold for having hypertriglyceridemia. The treatment of hypertriglyceridemia is not drugs. Don't give a casapen ethyl to these people, get them to lose weight. That's the correct answer. And this shows from Framingham why it matters. Hypertriglyceridemia in Framingham, if you look at triglycerides on the horizontal axis and relative risk on the vertical axis, you can see that there is a relationship, strong relationship, between higher triglycerides and higher risk, relative risk of coronary disease. This is baseline weight in several medical and surgical trials and C-reactive protein. And this is now in milligrams, per liter. And you see that these surgical trials, these people are very obese, but it's quite extraordinary that as weight goes up, CRP goes up. And the R value here is 0.76, pretty good R value. These folks up here in the surgical group have obviously a lot of obesity. They're patients getting bariatric surgery. So pro-inflammatory effects of obesity. This is the percent of patients with CRP levels greater than 2.2, which is a pretty important cut point for having a lot of risk. A BMI of 30, 40% of men have a CRP above 2.2. A BMI of 30 in women, 60% have a CRP of greater than 2.2. And these CRP levels are strongly associated with cardiovascular risk. I've already shown you that. So can weight loss favorably affect these risk factors? Well, here's the effect of weight loss on triglycerides. Now, it takes a fair amount of weight loss, but this is in milligrams per deciliter. If you can lose 15% of body weight, you can drop 70 milligrams per deciliter. If you can lose 10 to 15%, you still have 50 milligrams per deciliter reductions. And so it is a very important concept that the treatment for hypertriglyceridemia in general is weight loss. It's the most effective treatment that I'm aware of. The LDL HDL ratio, again, gets better. HDL goes up, LDL goes down a little bit. Certainly improvement in these lipid parameters with weight loss. You got to get in that 10 to 15% category to make a big difference, but even 5 to 10% is well worthwhile for most patients. What about hypertension? So 8 studies, this is a Cochrane review. Mean dietary weight loss is just 4 kilos, and mean systolic blood pressure reduced by 4.5 millimeters. It's about what you get from one drug, about what you get from an ACE inhibitor or a diuretic. Doesn't take a lot of weight loss to reduce blood pressure. Very important to tell patients that, because it can make a big difference between being on a bunch of blood pressure drugs and being on few or none. This is what happens to CRP. This is with weight loss. These gold squares are surgical trials, and you can see with large weight loss, huge reductions in inflammatory markers. You get rid of that visceral fat, and your CRP goes down. You have less cytokines, you have less risk of inflammation. And this is again another study, average weight loss somewhat better, 7.9 kilos, highly significant reduction in CRP associated with change in weight, and that happened pretty quickly. Now, what about substantial weight loss? So I got to now tell you about our RCTs. We've been doing now here, our group at the Cleveland Clinic has been running several RCTs over a number of years, and the first of these was Stampede. The Stampede trial was bariatric surgery versus intensive medical therapy for diabetes. You can find the 1-year, the 3-year, and the 5-year outcome, 3 different papers in the New England Journal of Medicine. It's the only RCT I've ever published 3 times in the New England Journal. We randomized to best medical therapy versus gastric bypass versus sleeve gastrectomy, and followed the patients for 5 years. But we reported on data after the first year. They had to have diabetes with an elevated hemoglobin A1C and a BMI of 27 to 43, just 150 patients. What happened was just incredible. In the people that lost a lot of weight, here's what happened to their BMI. Their BMI went down by about anywhere from 20 to 25%, a little bit better with gastric bypass than with sleeve gastrectomy. The medically treated group did lose some weight, 4.4%, but not nearly as much as the surgical patients did. And here's what happened to hemoglobin A1C. There was a 3% reduction in HbA1c in the surgical patients. And it was maintained at about 2.5 to 2.8% for 3 years. The medical therapy group got intensified medical therapy for their diabetes and did well initially, but look what happens. They rise back up such that after 3 years, they're only 0.6% lower. The drugs we have for diabetes are largely not durable. Weight loss is durable. It virtually cures diabetes. These people were on insulin, they went off insulin. It's unbelievable what we saw. This is the number of diabetes medications over 36 months. And you can see the medical therapy groups on an average of 2.6 medications. The the gastric bypass patients are on less than 1 medication on average. Some of them are on a little metformin, but they're not on much else because their diabetes has gone away, has largely gone away when we induced weight loss with surgery. This shows you what happens to risk factors. And again, HbA1c, HDL went up 13.8%, triglycerides went down 56 milligrams per deciliter, and CRP went down 2.6 milligrams per liter, a little bit better with gastric bypass than with sleeve gastrectomy. So then the question is, can diet or drug therapy favorably affect atherosclerotic cardiovascular outcomes? Well, the NIH made their best effort. They did the study known as Look Ahead, 5,000 patients, cost about $100 million to do this study. Huge investment by the NIH. These were overweight, obese patients with type 2 diabetes, and they got the most intensive coaching you can imagine. Every week, I got seen almost every week. They had very skilled dietitians. They were put on prescribed exercise programs, and the other group got standard care, standard diabetes support and education. Weight loss through decreased calorie intake and increased physical activity. And the primary outcome was a composite of CV death, non-fatal MI, non-fatal stroke, or hospitalization for angina. They were followed for a median of 9.6 years, long-term study. Here's what happened. It was unbelievably disappointing. They lost about 8 kilos and then they regained it. Actually, the control group and the intervention group were merging together such that the area under the curve here, or the main effect, was an average of 4 kilograms of weight loss with this unbelievably intensive program. Well, did that help these patients? Not a bit. This is the primary endpoint. It's as close to a neutral result as you can get. P equals 0.51. And so this intensive lifestyle alteration program just didn't work. And then along comes these drugs. And we have a sad experience with sibutramine. Mean placebo-subtracted weight loss in this large study known as SCOUT. They did have improvement in some biomarkers, and they were required by the European Medicines Agency to do a cardiovascular outcome trial, which they did. I won't go into the details because I want you to see what happened. They lost a little bit of weight, 1.7 kilos, with this pretty potent drug for weight loss in almost 11,000 patients. And their risk of CV death, MI, or stroke was increased. P equals 0.2, 1.16 hazard ratio. They lost weight with this sympathomimetic drug, but they did worse. And if any of you are using phentermine, it's no different. Phentermine, if it were studied, I have no doubt that it would be just as harmful as sibutramine. And here's what happened to diabetes. Diabetes got worse in the sibutramine treated patients by 0.22%, and it was in fact statistically significant at all time points. So what are the established benefits of weight loss drugs on clinically important cardiovascular outcomes? The slide is intentionally left blank. There are none. Weight loss drugs have been, to date, largely a failure, although there are some drugs in study that may do better. So I'm warning you about sibutramine. It's never been studied. I think there's a great deal of uncertainty whether any sympathomimetic drug that reduces appetite is appropriate or safe. And lorcaserin, you may know, was approved and then withdrawn because it increased the risk of cancer. Horrible, horrible result from these drug studies. So then the question is, what can we do? Can more substantial weight loss affect adverse cardiovascular outcomes? Dr. Minion and I, together, he's our bariatric surgeon and a fine, fine guy, did this study we published in JAMA in 2019, where we looked very carefully at the effect of bariatric surgery on cardiovascular outcome in patients with type 2 diabetes and obesity. And here's what happened. The weight loss was about 15% in the non-surgical controls. And this is not a randomized trial. This is a cohort type study. It's actually retrospective. So non-surgical controls, metabolic surgery, HbA1c in the surgical patients dropped significantly, p less than 0.001. And we looked at 6-component MACE, and I'll show you the components. Non-surgical controls versus metabolic surgery, hazard ratio of 0.61, a 39% reduction in major adverse cardiovascular events. Traditional MACE, which is death, stroke, MI, a 38% reduction. So in this carefully matched cohort study, there was a huge reduction in cardiovascular morbidity and mortality, but these people lost about 15% of body weight on average. That's what it takes to make a difference. All-cause mortality, 41% reduction, shown on the left. Heart failure, I've already said this, is very tightly linked to weight. A 62% reduction in the risk of heart failure. This goes out 8 years. Non-surgical controls compared with the surgical patients. Remarkable finding. Coronary disease, 31% reduction. Cerebral vascular disease, 33% reduction. Each of the individual components was individually statistically significant, not just the composite. Kidney disease, nephropathy, a 60% reduction in doubling or rather a 50% increase in creatinine or end-stage renal disease. Metabolic surgery patients did not develop end-stage renal disease. They did much better. And atrial fibrillation, 22% reduction. And I showed you earlier that that's linked to obesity. So if you can get 15% of body weight off of a patient who's significantly obese, and that's not that much if you think about it, you can in fact have a transformative effect on the outcome for these patients. More recently, we published also in JAMA a study known as Splendor. This was one where all the patients that underwent bariatric surgery had a liver biopsy. So we know that many of them had non-alcoholic steatohepatitis. We matched them up with patients who had liver biopsies who did not have bariatric surgery. We did very carefully, doubly robust matching. You can read the paper and you can see what our methodology was. Here's major adverse cardiovascular endpoints, not surprisingly, but they were lowered by 70%, 70% in these patients. Number needed to treat of 7.2, 15.7% event rate versus 8.5%. That shouldn't surprise you. You've already seen this. But here's the surprise. This is development of cirrhosis and other major adverse liver outcomes. About 10% of the non-surgical controls developed advanced liver disease, 2.3% of the metabolic surgery patients. I've been doing studies for a long time. I don't think I've ever seen a hazard ratio of 0.12. It's almost a 90% reduction in risk when you lose weight of major adverse liver outcomes. Well, what about newer pharmacological therapies? Can we get there without obviously we can't do bariatric surgery on everybody. We can do it on some people, but not on everybody. What about newer pharmacological therapies? Well, semaglutide, the GLP-1 agonist, does produce rather robust dose-dependent reductions in weight, getting out to maybe about 10% or so. This is an optimal study. There's reasons to believe that in the real world, it may be not quite that good, and it's dose-dependent. You have to give these big doses of semaglutide to get there, but it's a pretty good study. We've been interested in dual or triple agonists, And I want to talk with you about that a little bit. So we have GLP-1 agonists, we have GIP agonists, and we have glucagon receptor targeting drugs. The first two we have been able to study with a drug known as tirzepatide, will be approved relatively soon by the FDA. And you can see that in the top dose of 15 milligrams, there was a 13.1% weight loss. This is in the ballpark of what you see with bariatric surgery. Semaglutide did well, and this is now randomized trial. They got about half the weight loss. Now, this is not the top dose of semaglutide, which would have been somewhere in here, but this dual agonist, which is a GIP GLP-1 agonist, was able to really lower weight by a lot. Now, Brown and Goldstein, if you know them, wrote this piece in Science in 1996 after the discovery of the LDL receptor and the development of statins. And this is after 4S, and they said, look, heart attacks going to be gone with the turn of the century. By the year 2000, no more heart attacks. And of course, you all know that wasn't right. I think what Brown and Goldstein, who are brilliant people, what they missed is the power of the modern American diet. So I've been searching the world to find the world's most atherogenic food. And I thought I should share it with you. So I want to show you the world's most atherogenic food. I found it in Scotland. It's a deep fried Mars bar. You take a Mars candy bar and you batter it, and then you deep fat fry it. It comes out this nice, warm, gooey mess. You eat it, and it goes straight to the left main coronary artery. So let me summarize. Obesity increases rates of coronary disease, heart failure, stroke, atrial fibrillation, and mortality. It is abdominal obesity, waist circumference, that is more closely linked to adverse outcomes than BMI. Cardiovascular risk is increased even in physically fit and metabolically healthy obese patients. The mechanisms of harm include glucose intolerance, hypertension, inflammation, increased triglycerides, and low HDL. Weight loss reduces these risk factors, but as far as we can tell, only very substantial weight loss has been linked to reduced cardiovascular risk. Thank you very much for your attention.
Thank you, Dr. Nissen, for that wonderful presentation and beautiful review of the literature where we are up till today. Dr. Marcus from the audience has a question, and I know she has difficulty with her microphone. So I'm going to ask her question for her, and that is whether or not postmenopausal women are different than premenopausal women, both in terms of their susceptibility to cardiovascular disease vis-a-vis obesity, and whether or not their inflammatory markers are different because their profile of weight gain is different from premenopausal women.
Yeah, it's a great question. It's one I cannot answer. We don't have any data from any of the studies that we've done. It's really a good thing to look at. I think it's actually important because metabolism changes after menopause. We know that, and women start to catch up with men with respect to cardiovascular disease. So we ought to try to maybe understand the mechanism, and it may well be that CRP, inflammation, abdominal obesity, some of these things may well in fact be the explanation, but I can't answer that definitively for you.
Another question, what about the, you mentioned at the end of your talk about the GLP-1 agonists.
Yeah.
But when you compare the weight loss of 14% with some of them with what you can find in some bariatric surgeries, what is a clinician, what would you recommend first to your patient? Trying the medical therapy and then proceeding to bariatric surgery or not?
I think it depends on their level of risk, and there's lots of factors. one of the problems we have is these drugs are very expensive, unfortunately. I wish they weren't because we could give them to more people. The game changer may be tirzepatide. Now, let me reveal here to you that I'm about to launch a mega trial, 15,000 patients in non-diabetic obese patients using tirzepatide to try to reduce cardiovascular risk. Got a great executive committee. I think we're going to be able to answer the question, and we'll see in a few years. But from my point of view, it's always better. Medical therapy is always better than surgery. You know, if you can get the same results from medical therapy and not have to have all the risks associated with surgery, then I think medical therapy makes a lot of sense.
Dr. Jones, can you unmute yourself and ask your question, and then Dr. Fornoni?
Sure. So my question has more to do with advocacy, I think, because I am a hepatologist, take care of a lot of patients with fatty liver, and many of the ones who need bariatric surgery the most can't get approved for it. Do you have any insight on that? Since it's obviously striking in your slides.
Yeah.
How do we get people to cover it?
Yeah. Well, first of all, thank you very much for the question. I was just stunned by the improvement in liver outcomes with bariatric surgery. So, you know, we fight these battles, and when I battle with, whoever it may be, pharmacy benefit managers, insurance companies, I have a tool in my office that has proven to be extraordinarily effective. It's actually right over there behind my door. It's a aluminum baseball bat, and I get it out and I go after them aggressively and tell them that they're denying a patient. Who wants to get end-stage liver disease? Some of these NASH patients are in a rapidly accelerating pathway, and if you can get them operated on, you're going to stop the disease. That's what our study showed, and so it's really, really something we've got to find a way to get through.
Dr. Fornoni.
Thank you, Dr. Nissen, for the excellent presentation. When you show us that weight loss is associated with a partial reduction of blood pressure, is this equal if we achieve weight loss with diets or with bariatric surgery? And the question is it just driven by decreased salt intake or actually by the weight loss per se? It's a great question. And so what you may remember I showed you was a whole bunch of different studies. And so, to me, it sure looks like it works for however you lose weight. And, we see this. We certainly see. I have patients that I have had that are on 3 or 4 blood pressure drugs that are obese. And I say, look, I got nothing more to offer you. If you don't want to get a stroke from your hypertension, you got to lose weight. They lose the weight and their drug requirements go down. So I do think it's an effective strategy, but hard to achieve. And our dietitians try, but it's just it's a struggle for people.
Dr. Bernal Mizrahi.
Thank you, Dr. Nissen. That was a wonderful review. And I'm just curious about the new trial, and also with knowing that these single agonists or dual agonists can have direct effects on the heart that are independent of the weight lowering effect. Yeah. How you can really dissect the differences between these agents and, for example, bariatric surgery?
We can't, this is a debate. So the bariatric surgeons believe that the metabolic effects of bariatric, they call it metabolic surgery here because they know that it affects gut hormones. And so all we're doing then we give the GIP, and by the way, tirzepatide is more GIP agonist than GLP-1 agonist. We give that dual agonist. Some people would argue we're doing the same thing that metabolic surgery does. But for us, we don't really care. What we really want to know is, can we give a drug and get people to lose weight, improve their metabolic profile, and prevent, major adverse cardiovascular events? We're going to answer that question. And it's a really interesting study. We got a terrific executive committee. We got hepatologists on there, and we got endocrinologists, and we got cardiologists. And it's a real mix. And I think it'll be a lot of fun to do that trial.
Well, I want to thank you so much for your Grand Rounds presentation today. We're all very grateful. We welcome you with a warm heart to come to Miami.
January.
Okay, good. and I would ask everyone to check the new link to this the CME and MOC credits that are in the link in the chat. So thank you, everybody. Have a wonderful and safe day. And thank you again, Dr. Nissen.
Thank you very much, Roy. And thank all of you for coming.